Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this Aspen podcast. Let's get started. Welcome to episode 3, season 3 of the Pain Unfiltered podcast. I'm your host, Dr. Patrick Buchanan. Is with me, my co-host, Dr. Timothy Deere. Tim, how you doing as the annual conference in Miami closes in?
You know, Patrick, as we build towards Miami, Fontainebleau Hotel, July 17th to 20th, my excitement keeps getting higher because so many great things are coming forward, you know, for abstracts, for submissions, for studies, for late-breaking research. So I think the state of, minimally invasive spine and innovation, science, and neuromodulation have never been better. And I think we're going to see that in Miami. And I look forward to seeing everyone and networking and getting new projects going. So I'm feeling great. How are you feeling?
Yeah, great. It seems to be getting bigger and bigger. I think we've already had over 300 abstracts submitted, which I think is a record for that. And it's going to keep going. We're also going to have a special Pain Unfiltered podcast episode in a couple of weeks featuring Dr. Melissa Murphy and Dr. Kaz Emmer-Delphin. They've done a great job organizing the meeting, and we're just going to go over kind of a deep dive into the content and what to expect for the meeting. So look out for that in a couple weeks. Would love to announce our second sponsor of the season, Spinal Simplicity. Tim, they've been sponsored all 3 seasons for us, and so we really appreciate their support. They have 2 tremendous products out on the market right now treating spinal stenosis and SI joint dysfunction. Tim, just give us some of your thoughts on Spinal Simplicity.
Well, I think all innovation comes from the top and to the team that's built. And Todd Mosley there, the CEO, has built an amazing team. And I think that really says a lot about, the leader of who they choose to surround themselves with. So that's great. I've been working recently with them on a few new studies we're going to be doing for additional outcome data, which always helps with patient access. And then they're working on a few new projects I can't talk about because of confidentiality agreements, but I think they're working on some new things that will also be very good for patients that are less invasive, less risky, and hopefully more efficacious than current standard treatments. So I think, I'm not surprised they're sponsoring this podcast. They want to talk about new innovations with people like our guest today and really share the collaboration of industry, research, and business together with physicians and nurse practitioners and PAs to where we want to go.
Yeah, looking for their studies and the results and pushing this, this industry forward. So, Tim, we have a special guest today discussing the medtech sector. He's had a vast amount of experience in the industry. I've got to have the pleasure to collaborate with him at his time with Abbott. One of the brightest minds, I think, in this space. He's now the managing director at Deloitte. Brad Maruca, thanks for joining us today.
Yeah, thanks for having me.
Yeah, our pleasure. Let's start off with, can you share your journey in the industry, starting off beginning with ANS and talk about how you got to where you are right now?
Sure. It's a long and painful journey. No, it was great. I spent 26 years in medtech. I started out at vascular access, did that for about 8 years. And then I moved into, at the time, advanced neuromodulation systems. So that was 2004. About a year later, they were acquired by St. Jude Medical. In 2017, they were acquired by Abbott. So I really spent 19 years really in the same, roughly 1 or 2 therapeutic areas, but really focused on neuromodulation as a technology. Had lots of different roles while there. I started out really in marketing, moved into regional sales management, product management, KOL engagement, which gave me the opportunity to work with some of the brightest minds in the space, which was really a great experience. I'm actually still in counseling for some of it. And then I moved into clinical research strategy, which was really kind of an odd choice for a non-PhD. But I think through all the years that I'd spent in med ed and with the key opinion leaders, I learned a lot about what they liked about the research they were doing, what they thought the gaps of the research that they were doing, what they felt about the competitive landscape, and where we could be really helpful, and use that with some really brilliant scientists in order to draft, protocols, work with them on investigator-sponsored studies, and funding some of the physicians' interests for research as well. And so I actually found it to be one of the most rewarding, although probably the least obvious fit for me, probably one of the most rewarding positions that I had in the space. And then in August of 22, moved over to Deloitte.
So Brad, let me ask you a question. It's a 2-parter. So I'm going to take a little pressure off Patrick just for a moment. Part 1 is, What do you do at Deloitte? What's your job? So our listeners will know what your role is there. So that's part one. What's your current job? What do you do?
Hmm. All right. You want to get the second, or you want me to answer the first?
That's one question.
All
We're
right.
gonna more.
Yeah, so really, my area is the broad areas within life sciences. Life sciences basically has two legs to it. There's the pharma side, and then there's the medtech side. I focus only in medtech, and then my area is to be a strategy architect. So I do strategy, analytics, data. So I really work across all the medtech segment in order to develop commercial strategies, develop clinical strategies, medical education strategies. I mean, my experience set was really around the commercial side. So I'm really focused on growing revenue, growing penetration of really promising therapies into areas where they can be helpful. And so I really partner with organizations in order to do that work. And there's a ton of enablers in there too, right? Like, so if we think about industry partners, medtech partners, one opportunity is really to, automate some of their customer relationship management. So to what degree they go into a meeting with somebody like you, Tim, but understanding the society involvement that you have, the policies that you're collaborating on with industries and other regulatory agencies. They understand your publications. They understand kind of where you were trained, and what your background is in terms of your natural penchant for certain technologies and therapies. And so part of this is just to equip them to have a more informed conversation with you. Not to be creepy about it, but more just to have the background necessary to engage you at a level that saves time and gets you to a point where you can realize whether or not this is a benefit to you and your patients.
No, that's great, and that answers the question well. So, in part two of that, building on that answer, is really how is it your the first question Patrick asked you about your history, and now your current role. How has that helped you really advise companies about the pain space, and then what do you see as the current trends in medical device outside of pain?
Yeah, sure. Well, I've learned a couple of things. There's two primary things that I've learned. One of them is that you don't want to be too right too soon. I think really, you have these brilliant industry leaders that are really focused in their area, and they have a problem. And one of the mistakes I see some of the consulting companies make is that they'll come and they go, "That's exactly the problem," without really understanding it fully. So the idea is to really spend some time really getting deep into understanding their therapeutic area, understanding their I'm my customer's customer, in this case, the physicians, and really trying to get a sense for what is the real cause of the problem and how can we solve it or amplify it in some cases. And so the first rule is don't be too right too soon. I think the second one that I've learned is that typically the people that need the most help are the least likely to ask for or accept it, which is super interesting. But I get it. Like, there's this element of this again where you're so deep in your therapeutic area and you feel like you understand it deeply and you have an unsolvable problem. But in almost all cases, it's a solvable problem. And one of the key things I've learned is the problems that we have aren't isolated to our individual companies, our individual therapy areas, our individual specialties. There are core themes that emerge across all of medtech. Many of them have the same problems, and then when you work with them, what you're trying to find out is, okay, well, their solution to the same problem is based very deeply on their capability set. What is their nature of competition? What do they do extremely well? So as I think about, like, I'll take the econ view of this, which we talk about this concept of perfect substitutes. Well, perfect substitutes is really a proxy for something that's a commodity. So we don't ever want to be in a situation where we're looking at a client and they could exit the market and nobody would notice, meaning that there's so many other offerings that are so similar that they could fill in that void and you would never miss them. So part of this is really to hone in on what they do that's unique in the marketplace, build off those capabilities to solve those actually common themes. So you could work with people in the same therapeutic area, but like I said, even though they have similar problems, they have very different capabilities in order to help them solve it.
Very good.
That's great. Yeah, I think you gave a great overview of kind of the challenges that some of the companies face. Let's dive into the specifics. What innovative technologies or treatments, specifically in the interventional spine space, are you most excited about right now?
Yeah, I mean, I think about technologies that have staying power, right? Those with which they have kind of a robust initial kind of a data set, and they have ongoing data collection. They remain disciplined about the addressable population and try to replicate their early clinical results. And they really don't encroach on other procedures, which is really a temptation for a lot of them. And I was just telling Dr. Buchanan, Dr. Deere, before you got on the line, that I lectured yesterday at Kellogg. And while there, I have case studies about kind of successful. I really talk about the role of reimbursement and medical device innovation. And in there, I won't name them for you, but I've got case studies where it was done right and case studies where it was clearly done wrong. And one of the areas where it's done wrong is when it encroaches on another space, it encroaches on another CPT code. They take the shortest path to market entry. They don't do the work in order to establish the efficacy. They do the safety piece and the substantial equivalence, but they don't have the discipline to do the efficacy. And that's where things fall short. One, from just an adoption perspective, where people have a higher and higher threshold for clinical evidence in order to make a decision for their patient's well-being. But the other piece is the payers. I mean, when I think about the stakeholders involved, my hardest stakeholder wasn't CMS. It wasn't the FDA. It wasn't the practitioners. It wasn't the patients. It wasn't the facilities. It was the payers, right? And so when I think about the staying power, so with that kind of preamble, I do think that BVNA is probably one of the more exciting things out in the field. I think that they have an opportunity to be one of the more ubiquitous interventional spine tools in the space. And so that one's probably what I'm most excited about, specifically in the interventional spine space.
So, Brad, that's a good thought. So you mentioned a little bit about different really markets and access and payers. So we know the payers in the U.S. are different than the payers in the EU or in Great Britain. So, Aspen is now, we have a growing division called ISPN, which will become its own division separately by January of next year. It's currently, it will still remain part of the Aspen family. So we're going to be going to London in October. We're going to be going probably later next year to either Spain or the Netherlands or Germany. So what are you seeing the global pain market? Is America where it's at, or are we going to see growth in the global markets as well, do you think?
Yeah, I mean, I do think we'll see growth, right? But it's a percentage growth on a smaller base. I mean, if you took neuromodulation as an example, 80% of that market resides in the U.S. And some of that is just a function of access to technology, its acceptance of technology. It's also being able to harness kind of the referral pathway. I believe in some of the international markets, if you think about where you can do direct to consumer marketing, for example, there's only two markets where you can do that: the U.S. and New Zealand. Right. Right. So there's an element of this where there's some gaps with regard to awareness. There's some restrictions with what you can do for referral development and awareness. And there's just simply some points of access, right? You don't see the ambulatory surgery center as a prominent offering within other countries. So I do see them growing, and I see them growing just based out of necessity, but on a smaller base. Do I see them getting as big as the U.S. market? Not in the near term. I think we'd have to make some pretty significant changes. I mean, I remember when we were trying to enter markets like China or enter markets like India, one of the things that we would have to do as an industry to contemplate that is to have a lower cost offering for those areas. And so from an industry perspective, we were trying to make a choice about the service burden and how to enter the market and what we could, really support based on that cost offering. And we'd almost always gravitate towards leaving some of these critical features into the product rather than defeaturing the product to participate in some of these lower cost markets. And so I think that's a decision that has to be made at a commercial strategy level and specifically at an R&D level. They have to develop products that can really serve the needs of the population and whatever reimbursement system is established there.
Brad, you mentioned one of the biggest challenges for innovation in this industry is, payers. And in our first episode with Dr. Beal, we discussed the challenges of the SI joint fusion code and payment and reimbursement. So, how do these regulatory changes impact this sector, and what can us as physicians and companies that you consult, kind of improve this and try to take this forward?
Yeah, I kind of alluded to this early on. The regulatory pathway is often a key driver of some of these startup companies, right? And so if you've ever seen the documentary Bleeding Edge, right, they talk a lot about the 510K pathway. And the 510K pathway, again, just requires that you're substantially equivalent to something out on the market. But you have a safety hurdle to get over, but you don't have an efficacy hurdle to get over. So you don't have to run a clinical study, a pivotal study in most cases in order to enter the market. And so I think that that's actually works against them, right? They take the quickest path to market, which is this 510K pathway, and not doing the clinical studies, but that hurts them ultimately if they don't have the efficacy data to back it up. Because you see the contrast, right? Like I want to tell the FDA that it's substantially equivalent, but when I get out to market, I want to talk about how different it is, right? Like that's the tension that exists. And so they get this restriction where they can't really make those claims because they don't have the evidence to support it. And so that's what the companies. So the more disciplined companies will do that efficacy work. They will do that clinical data. And so I think it's part of the challenge they have. And the other thing I see is from a regulatory perspective, there's almost a conundrum of choice. There's so many options that are out there, and I'm sure you guys see it, right? Because you're trying to practice medicine, you're trying to see your patients, and you're trying to do your best to make sure that you're exposed to the latest technology that's available, and you're trying to budget into your day meetings where you can learn about these new technologies from the company representatives. But there's a great experiment. It's a consumer experiment. It's a great experiment to talk about the conundrum of choice. And they actually used jellies, right? And they did this end cap experiment at a grocery store. And the end cap experiment at the grocery store, they basically had 3 different jellies to choose from. I can't remember what kind, but say grape, strawberry, and orange marmalade, whatever. And so they had 3. And then what they did is they measured the amount of sales based on 3 choices. Then they reran the same experiment at the same end cap at the same time period in the same location, but now they did 6 jellies, and all of them were really precise. Now they had blackberry, and they had all these other choices, and the sales went down once they increased the amount of choice. And I do think that there's a little choice anxiety that occurs, and so unless you have the efficacy data to surmount that choice anxiety, and it's clear that it's beneficial, and for what patients it's beneficial, right? That's the key. You're thinking algorithmically about your practice and your patients, and if it's not clear, like if they, the temptation is to say it's good for everything, but if you say it's good for everything, you have no idea what it's actually good for, and you have to do that on your own. And so that pioneering work then shifts from the company doing that work to the practitioners doing that work. And so I think the regulatory pathway for some is too soft, and so they're out in the market, but then they fight the battle in market. And so I think that's part of the challenge.
I love the way you describe the 510K process. I've seen exactly what you said. People get the approval, and then they say, "Oh, we're much better than they are." Well, you really weren't when you applied for the 510K. So, but I'm going to build on your anxiety choice. I think that's a good thing to talk about. You and I, we've worked together for a long time. We helped develop the burst therapy, both in studies and approvals. We helped develop DRG together. We helped develop Distinct for non-surgical back together in your previous life.
Mm-hmm.
But Aspen has embraced collaboration with industry in a transparent, compliant fashion, and we've attracted a lot of young, rising innovation physicians in the market, like Patrick, for example, who's done a fantastic job. So they want to collaborate with industry to help improve the space in a compliant and helpful way. But there's a lot of choices. If you want to do minimally invasive spine now, we may have 10 choices for a particular area. You've been a KOL engagement specialist with one of the major, Fortune 100 companies. What's your advice for young physicians listening to this podcast who want to engage with industry? And now you've played this role at Deloitte, previously playing the role as a KOL engagement person for industry. What advice would you give to those young doctors? How do this anxiety they have about who to work with, how do they choose and what should they do? What's your insights?
Yeah, I love that question. I think the temptation from the physician's perspective is to diversify the companies that they work with. And that can be good, but the companies don't really like that. And we're not feeling like we get a full commitment from the physicians to partner. And we worry a little bit about the competitive landscape. I always felt like, and since you kind of noted our relationship, I'll build on that, which is that I always felt like you and I were very conceptually aligned, right? So the advice I would give to these physicians is to find those companies for which you believe that you're conceptually, ethically, morally aligned, and you have the same interest. I think the temptation is to work with whomever will provide the most lucrative consulting agreement, but that's a slippery slope because you never want to be trapped in representing a company for which you don't feel like you have a really tight moral, ethical, clinical alignment with. So I would start with those that have an ambition that matches your own. Because I never felt like in our relationship, I always felt like we were partners. I never felt like you were an independent consultant. In some ways you were, right? You were an outside-in perspective, which I always appreciated, and you had a great feel for what was going on in the marketplace. You were able to represent. Mostly you would tell me what ideas I had that were stupid, which is also very helpful. It's like I used to tell them it's like panning for gold. I'm going to give you lots of ideas, and you pan for gold. And sometimes it was in the debate where we would arrive at common ground because he had a chance to talk about his point of view. I would talk about my point of view. But that's the dynamic you're looking for in a partner. You're looking for somebody who is truly collaborating with you. That you're not a mouthpiece. You're not a talking head. You're not delivering preset slides. You are collaborating on content development. You're collaborating on what are the inputs. What are the necessary inputs of a product in order to deliver the clinical outcome that you're looking for. And I would find that if the product's already done, or they're not taking your advice, or they want you don't have an influence over who you educate and how you educate, that's not a good partnership. That's not a collaboration. And so I always valued our relationship because I always felt like we were developing it together, and we weren't doing it together just to help Abbott or A&S or St. Jude Medical be more successful. We were doing it because we had a mission across the field. And so that's where we were. And part of it was how we defined our competition. This is my last point, which is we didn't define competition as our direct competitors. We defined competition as non-treatment. We were less than 10% penetrated in our therapeutic area. So should I really be fighting over that 10% with my other direct competitors that I'm unique from? No. My goal is to find out why it's not in these areas. My number one competitor was non-treatment or alternative therapies, right? So that was the battle we were fighting together. And so I always felt like it was such a great collaboration for those reasons.
Great insight, Patrick.
Yeah, I think that was beautifully put, Brad. Letting your morals and your thoughts and innovation, kind of mirror who you partner with. And I always take this from Jason Pope, who told me, like, let your practice and how you treat patients dictate on who you partner with and who you consult with. I think they go hand in hand, which leads me to my next question. Talking about the importance of patient-centric design in developing new medtech products. How do you kind of put those two and two together?
Yeah, it's a hot button now, right? And I think it's a little bit of a misconception. And the misconception is that the patients want control or the patients want choice. Really, they want to, in this case, they want to feel better and they want to trust the clinical decisions, and they want to make sure that those decisions are being made by expertly trained clinicians dedicated to improving care and have their best interest at heart. And so this idea of like active monitoring, active engagement, yes, it has a place. But if I think about what real patient-centric design is, it's the idea of a forgettable therapy. It's the idea that I just feel better without the preoccupation of interacting with my devices. And a lot of that was the birthplace of going to a primary cell device back in the day when we shifted to propane, or going to burst, which eliminated paresthesia. It was this whole idea of, could we create a forgettable therapy? So I do think the patient is at the center of those decisions. I do think the misconception is that the patients want to be heavily involved in controlling their therapy or interacting with their therapy, interacting with the company. Great, some might, and you have offerings in order to support those. But I think the lion's share of the population really just wants to feel better, and they want to trust the physician is making the decision on their behalf. I mean, one of the things that we've talked about is like the buzzword now is about market access. Can we access the market? Can I get care? I think the bigger challenge is patient acceptance. We've talked for years about, spinal cord stimulation. Would you be surprised to know that only 25% of patients that are identified as candidates are offered spinal cord stimulation trial, even just the trial, actually move forward to get it, right? And as I've spent time at Deloitte across all of medtech, this is true across virtually every therapeutic area. So that's where, to me, one of the bigger challenges are, which is not the market access, but the patient acceptance. And to what degree we can have a patient-centric approach to them and get them to agree to our clinical plan and educate them with clarity, and get them the outcome that they're looking for in ways that's not burdensome.
Brad, I think that's great insight. I'm going to ask you a kind of a nuanced question here, so we'll see what
Sure.
you think. So I had a good friend who recently went to his third medtech category, 3 different therapies, 3 different silos, unrelated to each other. Okay.
Yeah.
And so when we were talking, I said, well, how's the new therapy? And, it sounded to me as if the management at a high level management they had the same problems in all 3 silos. They were different products, different doctors, but the same problems existed, right? So I want to use that to preface this question. So we know that in the PNS market and in the SI joint market, for example, there's multiple companies that aren't big players. They're not the Fortune 100 companies of Medtronic, Boston, Abbott. They're small companies. Some of those are going to make it, and some of those aren't going to make it. So let's take, for example, an SI joint company.
Mm-hmm.
Your experience at Deloitte, what would be some of the if you're doing a case presentation at Kellogg again or at Harvard, what would be just some few things you would think are landmarks for you of the company that's going to make it versus the company that's not? When they're the same size today and they're competing, how are we going to be able to identify the company that's likely to excel versus that one who will go away and be on that pile of failed startup companies? How,
Yeah, I love that question. I'll give you a shameless book recommendation. You're an avid reader, so maybe you've read this one. So forgive me if you have it. There's a great book called Ending Medical Reversals. And it's a fascinating book. It goes through over 140 different technologies that have been in the market. And it's almost studying the adoption curve in reverse. So what they do is they take, okay, well, what are the typical ways that physicians make decisions
I'm
about
going
their
to make a note
practice?
of that. I'm going to make a note of that right now. I'm going to get
All
that.
right.
I've not read
And,
that.
and if you want to cheat a little bit, take a little shortcut. At the very back of the book, there's actually a table of all of them, and then the book itself goes into detail about what had happened. But essentially, what they do is they take accepted medical practice, what's already being done, and then they subject it to rigorous clinical study. And what they're looking for is whether or not the either the cost or the risk or a combination of those things offsets the benefit, right? And if it doesn't offset the benefit, then the recommendation, of course, is to reverse that accepted medical practice and stop doing that, which is really tough to do too, right? Because it's so ubiquitous already. But it studies the adoption curve in reverse. So if I were to take that example in your question, I think that what helps them survive is this evidence piece. Like, what is the evidence? And I also think about what you've been careful about in your entire career, which is collaborating across specialties, right? You embrace other specialties. So one of the pitfalls of an SI joint is, to what degree does the surgical community believe that the SI joint fusions encroach on a procedure that they could do, right? And so what actions would they take in order to do that? And so I think what would be key is, and you've done this in your career, so I'm already I guess I'm not reading your mail, I'm reading a mail that you already opened, which is that you have to demonstrate that this is where this fits and this is where it fits together with the other therapeutic areas. And so I think that as much as they try to be an independent offering, but if it encroaches on the other ones for which that might have been a better choice, that's when you start to get conflict. And so one of the examples that I gave yesterday in Kellogg, and again, I won't name the technology, but it just took a society to whisper in the ear of CMS to trigger national coverage analysis. And that coverage analysis has a comment period. That comment period had people who were talking about how it was used and what their individual experience was. And ultimately, they lost coverage. They were using the wrong CPT code. So I think, I'm sorry I keep pounding the drum of evidence. And I actually wrote what I thought was going to be a very provocative title, which is, what can medtech learn from pharma? And my medtech partners out there cringe at the idea that we can learn anything from pharma. But what we could learn from pharma is that every single one of their products that enter market are exposed to rigorous clinical study, and they're rigorously focused on the patient and patient access and affordability. And so, with as much as this has been really a topic of debate within the political sphere, they're wildly more successful than a lot of the medtech solutions. And it's because, I think, of this approach of evidence and patient access and patient affordability. And so I think those are the key areas to focus on.
I just want to make a follow-up comment before Patrick asks the next question. I think we have time for probably 3 or 4 more questions. But, a couple of things you just said that I love. Evidence is our currency, right? We have to have evidence. Without evidence, we aren't going to make it for anything we're doing. So I think
Right.
that's a great point. I agree with that 100%. The first thing I tell any startup company that I decide to work with is, the reason I'm here is to help you get evidence. That's why I'm here anytime I work with anyone. But second thing you said, I really think is important, and I have embraced the ortho spine, the neurosurgeon, the interventional radiology, physiatry and anesthesiology together. And I'm giving a talk at the Spine Summit, which is basically an ortho spine meeting in Cabo every year. And before, when pain doctors were even brought up
Nice
there,
venue.
when they were brought up there, it was like it's a major problem, right? So now I'm actually been invited to speak on the main podium there, and I
Love it.
think it really goes to show that we are, even those who were very divided, we're going to get like-minded, and we're going to have to, for patient access and for success with especially long-term of interventional spine, whether you be a surgeon, an interventionalist, or whatever you may be, or a collaborative company. So I do think everything you said, I totally agree with. I think that was a fantastic answer, Patrick.
Yeah, just to add to that, like you said, there's been a shift between the surgeons and interventional pain. Typically, back in the day, they were at odds and trying to become a turf war. Now there's more of a collaboration, and that's what Aspen's about, collaborating. You'll see a lot of that at the meeting as well with the panels. Where do you see this collaboration between interventional spine and the spine surgeons, orthopedic surgeons go in the next 5 years?
I think that is that future is going to be determined by things like that you guys are doing with Aspen, right? As long as you embrace each other, you look for opportunities that complement each other's clinical treatment modalities. People are operating within their license. They have the best interest of the patient at heart. They recognize the value in collaborating on the clinical care and clinical decisions. I think as long as you guys continue to fan the flame, opportunities like Dr. Deere speaking at these other society meetings, you having other specialties speak at your society meetings, you start to develop maybe an algorithm of care that extends beyond interventional pain management, but includes kind of the longitudinal pain pathway. And like, what does that mean? Where are the decision points? Where are the leakage points? Where can we optimize care? This is another area where I think AI can be particularly helpful, right? Where they can take hundreds of thousands of patients, go in medical charts, and look for ways to optimize those. And where the society can be helpful is like really crafting more this algorithmic approach to care. And I know that's been part of our passion for all the years that we've been in neuromodulation is to get at that, and all the work that you've been doing in publication and trying to get at what are the most exciting innovations, where can we insert those, what's the right sequence, what's the right timing. One of the core problems I have is timing. Like, I talked about this delay in care, or this denial of care, this patient acceptance component. Is your likelihood of success the same? Let's just say for a total knee replacement, on the year that you're offered it, or 5 years later when you accept it. It's worse. Your probability of success goes down. You're older, your physiology changed. You've probably compensated by putting more weight on the other knee. Now you've changed your gait and it affects your hip, right? There's all these other things that happen. So one of the things we have to attack as I say we, because I want to partner with medtech to do this, is as you create that collaboration, to what degree can we make sure that we have the optimal timing? So not just the idea of what do we offer, but what is the right timing to offer it that we get the best possible outcomes?
Yeah, that's great. The timing thing I love. I had a patient recently come to see me who wanted a posterior lateral arthrodesis performed by me because they had some friends in their community have it done and do really well. And they actually came to see me probably a little too late. They'd gotten more severe. And I sent them to see one of the neurosurgeons in our hospital because I thought they had a better chance of helping him. Had I seen her 2 or 3 years ago, I think she'd have had maybe a better chance.
Totally.
Saying minimal. Les, I want to ask you one more question, and then I'll let Patrick ask the last question. Then we'll have closing thoughts. Here's my question for you. You've been involved coming to the Aspen meeting, giving your insights, and I know that you really are an important part for us to understand the market. You and I talked about you proposing a panel in 2026 for Miami. Again, it'll stay in Miami. It'll stay on South Beach for the foreseeable future.
Or Cabo.
So, but here's my question for you. When you MedTech Horizons is something that Dr. Melissa Murphy and Dr. Kazimo Delfon have added to our program. It's a Thursday time to discuss, businesses, successes, corporations, venture capitalists, investors, and you're going to propose a panel next year to be held there. So here's my question. If you had that panel, and I don't want specific people, but if you had 5 people sitting on that panel and you're trying to help us determine how to create a successful startup that's going to become either bought by a strategic or go IPO eventually, what 5 people, what type of people would you have sitting there on that panel to tell us how to create a roadmap for a successful startup?
I love it. Well, I kind of rattled it off earlier, which is I kind of think about this in terms of stakeholders, right? Like we have I'll take 1 step back and then 2 steps forward, which is this idea of like, think about the dynamic here. So unlike my jelly example in the consumer environment, where the person who's making the buying decision is also paying for it and is also the beneficiary, those are fragmented, those are stratified within med tech, right? Where we have a different person that's paying for it and a different person that's making the decision on it and a different person that's providing the facility for it is a different person that's the beneficiary for it. And so as I think about what a panel might look like, as I would break out those stakeholders, right? And so to some degree, I would probably have an FDA representative. I would have a CMS representative. I would have a commercial payer representative. I would certainly have the implanting or proceduralist there and the referring physician. So my 5 would be to try and capture, who I think are the critical stakeholders. So, and because I've been in these meetings before, and when I ask someone, what's your commercial strategy? Crickets. What's your business model? Crickets, right? What's your clinical outcome? Here's my clinical outcome. Where's your evidence? The crickets, right? So there's this part of it where you have to have the discipline to not just have a quirky new idea that seems to fill a void. Like I'll quote Elon Musk, right? Which is that, engineers' problem is they try to optimize things that shouldn't exist, right? So part of it is the idea something that's refining a process that shouldn't exist at all, right? And so the first inclination should be to eliminate it, and then it should be to optimize it. And then how do you bring that to market in ways that'll reach market acceptance? And you cannot survive without really understanding the needs of the stakeholders, which are all different, and you have to satisfy those. So for me, those would be my 5.
Brad, you haven't given a bad answer yet, so you have one more chance to give a bad answer. Patrick gets the last question. All your answers have been fantastic. So Patrick, give Brad one more chance to answer a bad question.
Yeah, you've been on fire, Brad. So we started with a general overview question. We'll end with a general overview question. As we've seen lately, there's been a lot of acquisitions. Boston has acquired Vertiflex, BVN, as you mentioned. Nevro just got acquired by Globus. Two-part question. One, do you think this is a good thing for our space? And two, where do you see this going in the future?
Yeah. And look, I'll give you the other side of that, which is spin outs, right? So Stryker just spun out their spine business. Medtronic just announced this morning they're spinning out their diabetes business, right? So I think that the old school GE conglomerate structure to diversify businesses had a place in time. And I think what you're going to see in terms of a trend is a level of focus and clarity. And I will tell you, by being in an organization that's absolutely focused on neuromodulation, there are huge benefits to that. The area where I'd like to see some improvement is that when you have a company like Abbott, for example, we would have a medical device division, which was essentially legacy St. Jude Medical with the diabetes business grafted on, where I'd like to see, and then you have individual presidents that lead the business units. They have individual P&L responsibility. I would like to see kind of what I've been benefiting from playing across all of medtech, which is a level of collaboration. So why isn't the diabetes group working with the neuromodulation group to help with diabetic peripheral neuropathy, right? They're not really joining hands to do that. So on one hand, I would say that I think the area of focus is really important, which is one part acquiring things that enhance your portfolio and help you get customer, like commercial channel leverage. The other part is the spin out, maybe those slower growth, less strategic parts of it. Probably the most successful example of that was AbbVie and Abbott back in the day, that spin out to basically purify to a medical device, a group, primarily medical device group. So for me, I think it's going to be beneficial. My view is that it'll be beneficial as people spin out non-strategic value offerings and focus and acquire and continue to fold it in. Because I think about, I'll just take the example of us partnering together with you. You'd love if you have a great partnership with a representative, you'd like to buy as many things as you could from that representative. It streamlines your scheduling process. It enhances your relationship. They have a broader perspective of everything you're providing. And so I do think that there's a chance to amass multiple products to enhance the relationship with the customer and get channel leverage, so you can take down some of the noise and the inefficiencies of working with multiple companies in order to deliver device solutions for your patients.
That's another great answer. I think he's batting 100 today, Tim. So
Right, I think so.
We'll end up with some closing thoughts. Tim, you go first, Brad, and then I'll wrap it up.
Okay. So, I think today's podcast is definitely one of my favorites because we're talking about the past and the future and where we're going. And I think back, whether you're a religious person or not, I think, I always believe that I'm through certain situations in life because it's going to take me to my next situation. And if you have faith that, that's where you're going. And again, to each his own, I have no judgment on your religion. But if you believe that these experiences, good or bad, take you to this experience, and if you're blessed, something good happens to you, it wouldn't have happened had you not lived through the past. I think Brad Maruca today is a great example of that. The history he had and all those roles he played in a major medical device company, from the startup company ANS, which was teeny, which sold to St. Jude, which was bigger, and then now eventually to Abbott. And now he's left Abbott and to Deloitte, giving advice to multiple companies around the world. I think the previous experiences, Brad, made you who you are today and why you're so effective in this new role. And I think that physicians should take a lesson from that. Many of our younger physicians, they've joined 2 or 3 groups in their first 5 years, and it hasn't gone well. Mm-hmm. Maybe it went well, but they wanted to move locations, or, I think they need to take those early experiences and think of those in a positive light, even the ones that weren't great to them at the time, because it
Yeah.
can make you better later. So I will say that I've seen your personal growth over 20 years, and I love to see it. And I think your insights today were helpful to our members at Aspen, also to our corporate partners who work with us, and I think to the field as a whole to really share that knowledge. And I thank you for coming on. And I think it's been very enjoyable to me to hear everything you said. So thank you very much.
Thank you. Yeah, we lived it together. My wife calls me the slumdog millionaire, Tim, which is, all of these experiences, positive and negative, create this constellation of experiences that if you pay attention to them and you collect them and you act on them, sometimes the painful experiences can be the most powerful and the most positive. And so, my story because we lived it together. A lot, 6-year warning letter and remediation and recalls and 55,000 chargers being swapped out of patients' homes, right? But it taught us a lot about, well, what are we really trying to solve? What business are we really in? And so, yeah, I fully agree. And embracing those things are really important. My story about, my it's a real story about Enterprise, Alabama, and the boll weevil. And if you have a chance to look it up on Wikipedia, you'll see it. But essentially, it's the only city on the planet that has a statue to a pest. And it's because them attacking their cotton crops back in the day shifted them into peanut farming, and it ended up being a boon for the city. And so I think a lot about those negative experiences as my personal boll weevil. So
That's a great way to end it, Brad. Brad, thank you for joining us again. I think the key takeaways here is, evidence is our currency, like Tim said as well. That's going to push our innovation forward. Collaboration is huge with not only the partners in the industry side, but what's also within our subspecialties as well, the spine and interventional pain. And, we just want to thank you. I think you're a great asset for our space and pushing this space forward. And, I think the future is bright, and, we have, challenges to face, but I think we'll all get there together by collaboration and innovation, which is the theme of our conference this year. So thank you,
yeah,
Brad, for joining us.
thank
Thanks,
you.
Tim, as always, for your insights.
Yeah, and I love Aspen. I love your mission. I love your ambition. And I love the way that you're going about collaboration with industry, collaboration across specialties, driving the science forward. 300 abstracts is unbelievable. So I love what you guys are doing. And if there's any more that I could ever do for you guys, it's my privilege to do it.
Thank you very much.
We'll appreciate you, Brad. This wraps up episode 3, season 3 of the Pain Unfiltered podcast. Thank you all for joining us.